This program is rated PG. It contains themes and scenes which may not be suitable for very young audiences. Parental guidance is advised.
Be advised that the views and opinions of the hosts and guests do not reflect those of the station.
A dilemma is a situation in which one needs to choose.
Paano ako gagaling?
There's an ethical issue.
Enter the
Supposed
second.
to help first or
Medical Dilemma.
Hi, I'm Sonny Del Rosario, and you're tuned in to Medical Dilemma. There's a saying that the way to a man's heart is through his stomach. Well, that's assuming the stomach is healthy. For today's episode, we will talk about some of the most common ailments connected to the gastrointestinal tract that many Filipinos experience. Our guest for the first segment is Dr. Frederick Andre Lilin, specialist in internal medicine, gastroenterology, and an active consultant at Makati Medical Center. Welcome to the show, Dr. Lilin.
Mon, thank you for having me here. I'm glad to be here.
That's great. Now, first of all, let's talk about the basics of your specialty, gastroenterology. Okay, what exactly does gastroenterology cover?
To simplify it, any disease that involves from the mouth down to the esophagus, to the stomach, small intestine, large intestine, until the anal opening. So the entire GI tract, that is what our specialty is all about. And in between that, the abdominal organs that are also involved are the liver, the gallbladder, and the spleen.
And how do you become a specialist in gastroenterology?
Well, you of course finish a 4-year medical school. You take the
Yes.
boards, you become a doctor. And then you have to take a 3-year internal medicine training,
Okay.
at which time you will be known as a specialist in internal medicine. And then you just need to take an additional 2 years of what they call fellowship in gastroenterology. And
Okay.
when you finish that, then you're then qualified to become a gastroenterologist.
I see.
Now,
So-
sometimes some GI specialists, as I'm going to call them from here on in, take an additional year or two to further train in what we call endoscopic procedures.
endoscopic procedures.
Right.
Okay.
I mentioned endoscopic procedures because aside from treating diseases like a physician who we see patients in the clinic, we also do what we call endoscopy.
Okay. Endoscopy.
Endoscopy is a general term when you use a scope. So if you've had other specialists on your show here before, they take a look inside the ears. That's
Yes.
called endoscopy. When you take a look
Ah,
inside the nostrils, that's called endoscopy.
So it's
In fact-
actually a general term
Yes,
for
when-
examining the inside of
Correct.
the human body.
Using a scope.
Okay.
But particularly if you're going to take a look inside with the scope into the mouth onto the stomach, or from the other way around, from the anal opening into the large intestine, that's the kind of endoscopy that we do. In particular, the upper part is called gastroscopy,
Gastroscopy.
and then the lower part is generally called colonoscopy.
So gastroscopy goes all the way down into the,
Just to the stomach.
Just the
and-
stomach.
And to the beginning of the small intestine.
okay, and if it's the other way around from the anal opening, that's,
The entire colon, which is
Colonoscopy.
longer than the from above, so it's longer. But those are the two general procedures that we do.
I see. Are these painful procedures?
Nowadays, unlike before, most gastroenterologists sedate their patients for these procedures. In some other countries, they don't because of economics or numbers, but my answer to that, if it's a painful procedure, the direct answer to that is no, because
None.
you're sedated during the procedure.
Okay. But you're conscious. You're awake.
There are different
half.
levels. There are different levels of sedation that we use for this. But usually, what happens is the patient will not remember anything about pain, or any discomfort that they had during the procedure. They wake up, it's already finished.
I see. I see. So you're not really unconscious, but you would not sort of experience the experience.
Right. I mean, if you're going to compare it to if you're going to operate on someone,
Mm.
I think that's a deeper form of sedation. Ours is very mild, but it's just as effective.
I see.
So pain and discomfort is usually not associated with the procedure.
Okay, that's good to know. Now, what are the most common ailments connected to the gastrointestinal tract?
Here in our country, it's still what we call the infectious diseases.
Mhm.
You ingest something or you drink something
Mhm.
that has an offending agent,
Mhm.
a germ, a bacteria, a virus, dirt.
Okay.
No? It's contaminated
Mhm.
and it causes inflammation in the gastrointestinal tract. So
Okay.
that affects sometimes the whole lining from up to below, no?
Mhm.
Which is why you usually have vomiting and diarrhea as the
Mhm.
major symptoms of the number one GI disease, which is gastroenterocolitis.
Mhm.
What that means is the gastroenteral colitic tract
Mhm.
is inflamed by these offending agents, and that's the number one disease that we have in our country. It's what you would call related to food ingestion and hygienic practices. You have to have cleaner food,
Yes.
more readily available clean water, ability to wash your utensils and everything that you use. It's an offshoot of being a third world country.
I see. So the state of development of a country has a lot to do with these conditions that you have just described.
That's right.
And so the occurrence of such would be, I guess, less frequent in more developed countries?
What you have in more developed countries is what you call outbreaks.
Outbreaks.
Rather than in our country, every day you see it. And in fact, it's not really, if you look at the socioeconomic status, sometimes it's not even related to that.
Ah,
Of
okay,
course,
okay.
if you were to practice in areas that have poor hygiene,
Mhm.
maybe there are some areas that have no good running water, no clean living, then you'll see more of it. But in more developed countries, they experience more what we call outbreaks. There's usually an offending agent, which once they identify it, they can totally eliminate the problem.
I see. Now, are there other conditions that are less frequent than what you have described?
Well,
Probably those that are more serious, though.
Gastroenterology is moving towards, shall we call it, cancer prevention,
Cancer prevention.
right? If you say that there are more serious diseases, to this date, I can't think of anything more serious than cancer. If you know a friend, a relative maybe, or somebody that you know who's very close who has cancer, you know how debilitating it is on the
Yes, that's right.
whole family,
That's
plus
right.
the patient themselves. And fortunately, in gastroenterology, there's such a thing as early detection. If you were to compare it to other specialties, once you have a small lesion in other parts of the bodies, it's already cancer.
Okay.
In gastroenterology, you have a period wherein it's not yet a malignant lesion. It's just what we call either a polyp or a benign growth, which will only become malignant or cancerous at a later date. And if you had the capability to remove that small lesion, there lies the word prevention. No? You did not detect it, you in fact prevented it.
I see. So what's the time window, between?
It's the age.
It's the age.
If I were to have a patient who would come to me and ask me to evaluate a pain that they're feeling, if they were 35 years old or below, I would think that would be a very benign symptom. I wouldn't think of something malignant or cancerous. When they reach the age of 50, you start thinking that maybe this complaint is something malignant. So it's basically the age of the patient, which is a constant or something that you can readily see. What do I mean by that? Again, if I were to evaluate somebody who's only 25 years old, who's complaining of abdominal pain,
Yes.
I wouldn't take a look inside with the scopes that I mentioned earlier.
Mm.
If they were 50 years old, because there's a possibility that they could have something besides an infectious agent or something like hyperacidity, then I take a look inside. So
I see.
that's how we deal. It's the age usually. There's another factor that we look at as far as treating these type of diseases. They're called alarm symptoms.
Alarm symptoms. Right. And what are these?
And very easy to understand. It's weight loss.
Weight loss. Okay.
Pain that is severe or unrelenting.
Okay.
And the usual inability to eat or sleep well at night.
And these symptoms have to occur all at the same time, or
Usually,
maybe just 1 out of 3 or 2 out of 3?
Usually they will come in tandem. Usually at least 2, and hopefully not, but sometimes 3 of them will come in. And then when you hear that, then you think of a more serious disease pattern. Maybe not something that's very benign.
I see. Okay.
Um,
So in that case, having an endoscopy is not really necessary until you reach a particular age.
That's correct. The age that it is deemed to be helpful for both men and women is 50 years old.
50 or older.
Yes.
Okay. So
Even if you're, and I have to say, even if you're not feeling anything, it doesn't
even if
mean
you're not feeling anything.
yes.
Okay.
Because
That's something I don't know.
precisely because when you have a small polyp in your colon, which may become malignant in 20 years' time, you will not feel it because of the mere fact that it's small. There's no
Okay.
symptom. But you can detect it when you take a look inside, and you can remove it before it becomes malignant, like what I was saying earlier.
Okay. And taking out these polyps is part of your practice.
Yes. When we see it, it is beholden on us to remove it. And usually what we do is we give the patient a schedule for further endoscopic exams, meaning that might not be the last one that they'll have. The age 50 that I mentioned, wherein you undergo these endoscopic procedures, becomes -10 or less 10 if you have a first-degree relative who has cancer of the colon or cancer of the stomach. Let's say your mother or your father suffered from colon cancer, you should have a colonoscopy at 40 years old.
At 40 years old. So
And
that's
I hope-
-10.
Yeah,
Okay.
I think you can see why, because you cannot choose your parents. No?
Okay. So there's a genetic connection.
Correct. No, if only we could. No, I mean they say nga, friends are God's way of apologizing for your relatives. Di ba?
Well, yes, I've heard of that saying before.
So again, no, the endoscopic procedure for an asymptomatic, yung walang nararamdaman, is recommended at age 50.
Age 50. And then you just -10 if you have a relative that is suffering from some form of cancer connected to the gastrointestinal tract.
Correct. The term that's used for that, so that you can be more informed about it, is called screening.
Screening.
Yeah, and if you get the terminology that we're using there, screening means sasalain mo, titingnan mo kung sino yung mga meron, kung sino yung mga wala, kahit walang nararamdaman. Parang,
Okay.
if we could endoscope or colonoscope the entire population of 50 years old, no, we can eradicate colon cancer because we'll catch it early.
I see. Okay, well, we have to take a pause for a while, sir. Don't leave this channel. We'll be right back after a few words from our sponsors.
out of my mouth, especially in such a place where anything can spread like wildfire.
Why when you share something to a public, you find that experience, and that experience so rich it could change other people. Okay?
Encouraging the generation.
Like, there are other